start recording. All right, Madam Chair. Oh, let me share my screen.
Good morning, and thank you for attending our 5th subcommittee meeting for treatment and recovery. I appreciate everyone that's come. I will actually have Kelly call roll to establish quorum, please.
Thank you, Madam Chair. Kelly Marshall for the record. So I will just go through the list. Ms. Cheatham.
Present.
Dr. Dixon. Here. Mr. Iverson. Ms. Lee.
Present.
Mr. Shell.
Present.
Madam Chair, we have a quorum.
Great. Thank you, and we'll go on now to agenda item for number 2 for public comment. Public comment will be received via Zoom meeting. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. And Kelly, just some housekeeping notes for public comment. Please wait to be recognized by the chair to speak, and Kelly will note if there are any hands raised for public comment and alert the chair. Once completed, the chair will ask if there is any public comment from individuals who are joined by phone. So Kelly, please, do we have anyone ready for public comment?
Madam Chair, Kelly Marshall for the record. We do not have any attendees joined by phone. I do not see any hands raised by any members of the public.
Via Zoom. Okay, thank you. So now we'll move on to agenda item number 3. And we have draft minutes from August 12th subcommittee meeting. I would now ask members to review the minutes and to note any changes or corrections or make a motion to approve or approved as amended. Are there any changes to the August minutes? Right. With no changes, do we have a motion to approve the August minutes?
Madam Chair, this is Steve Shell. I make a motion to approve the minutes from the August 12th meeting.
Thank you, Mr. Shell. Do I have a second?
I'll second it, Dr. Dixon.
Thank you, Dr. Dixon. All in favor, please
Aye.
raise your hands or signify by yes.
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 Any opposed? Any abstentions? The motion passes. Thank you. So agenda number, item number 4, we have a presentation from subject matter experts. Today we will hear from Tina Willauer and Chief Judge Lynn Simons. We will start with Tina Willauer. Welcome, Ms. Willauer. Ms. Willauer is a program director for Children and Family Futures. She is here to present on the National START model. START stands for Sobriety Treatment and Recovery Teams. It is a specialized child welfare service delivery model that improves outcomes for children and families afflicted by parental substance use and child maltreatment. There are 2 handouts provided by Ms. Willauer in the meeting posting for your reference. Welcome, Ms. Willauer.
Thank you so much. You just kind of you kind of gave away my first few lines, so you saved me a little bit of time. So that's good. I'm really happy to be with you all today, and just thank you for the opportunity to come talk with you about START. I'm coming to you from Louisville, Kentucky today, and I'll just say that I've been working in START my entire career, almost of 32 years in child welfare. So thank you. Let's jump right in. All right, what is START? Assemblywoman Thomas just kind of shared a little bit about that, but I'll say it again. It's an evidence-based child welfare-led intervention for families who actually come to the attention of the child welfare system because of substance use concerns and who also have at least one child between the ages of 0 and 5. And that includes infants with prenatal substance exposure. You would think about this model maybe as a practice or a service delivery model, or a specialized unit within Child Protective Services or the child welfare system. I kind of use those interchangeably. It's not a treatment program, and folks sometimes misinterpret it. So it's not that. However, the model is implemented in partnership with behavioral health treatment providers because we can't do a collaborative model like this without them. The model helps parents achieve recovery, and it keeps children in the home when safe and possible to do so. START uses a family-centered approach, meaning we serve the entire family, and we really focus on providing services that will help that bond between children and parents, and of course, recovery and treatment services. The model really oftentimes is used by jurisdictions as a catalyst to transform the system of care within and between child welfare, behavioral health treatment providers, courts, and other family-serving systems and agencies. So a little bit about the components. So staffing for START, the model pairs a child welfare worker with a family mentor. And those two together are called a dyad, and they're co-located in the child welfare office. Family mentors are amazing. They're individuals in long-term recovery from their own substance use disorder, and they also have past child welfare lived experience. Their job is to provide peer support services and to share their lived expertise with families that come into the child welfare system. So family mentors help navigate the system with families, so child welfare system, treatment, courts, whatever public system families are working with. They help parents get into substance use disorder treatment. They actually drive the parents to the first 4 treatment appointments to make sure that they get there and to do that warm handoff with the provider. They introduce them to recovery supports in the community. They help them kind of work through parenting in early recovery, and all this through the lens of child safety and family well-being. The worker and mentor dyad shares a capped caseload of up to 15 families, and they provide intensive case management services. And a full START team actually consists of multiple dyads, and that's really based on the need in that county. START uses a group of strategies and an accelerated timeline of activities during the first month of a child welfare case, and that's far earlier than typical child welfare services. Some of the strategies include quick access to substance use disorder and mental health treatment assessment, as well as treatment services. We use shared decision-making with our community partners and families. We have a mantra, nothing about me without me. We don't want to make decisions for families without them being at the table. We use motivational interviewing and importantly, a non-punitive approach to engaging families. It's kind of a departure from maybe what we know as typical child welfare services. We also see families weekly to support them and to also check for child safety. So within the first month of a case, we're talking the report to child welfare. Within that first 30 days, this family is going to be referred for START ongoing child welfare services. They're going to have met their worker and mentor dyad. They're going to have gone to their first family team meeting. They're going to have had their substance use disorder mental health assessment, been referred to treatment, and actually attend a minimum of 4 treatment sessions all in the first month. It's very much quicker than typical child welfare services and how they work. And our research tells us that this early engagement of families actually results in better outcomes for parents and kids at the end of the case. So let's talk outcomes. In START, we believe in rigorous program evaluation and the use of data for program improvement and fidelity monitoring. Over the past 15 years, we've had numerous studies. I want to say it's maybe around 10 or 12, basically to understand the effectiveness of this model with kids and families. And here's what we've learned so far. Women in START have nearly double the sobriety rates of their non-START counterparts in traditional child welfare services. So about 66% in START versus about 37% in the general child welfare population. Children in START are half as likely to enter foster care at about 21% versus 42% in general population. At case closure, about 75% of the children in START remained with or were reunified with their parents, and the parents actually showed improved parental capacity. So that's important too. We wanted to know if these results held. So we did another study and looked at kind of sustained effect. What we learned was at 12 months post-intervention, so a year after the family's case in child welfare is closed, more children in START remain free from both out-of-home placement and recurrence of child abuse and neglect as compared to traditional child welfare services. So about 68.5% versus 56%. We also decided we needed to do a study to see how African-American families did in START as compared to usual and traditional child welfare service. This is super important because we know that families of color are overrepresented in the child welfare system and their outcomes are worse. And in START, we don't want to contribute to that problem. So what we learned about that is at 12 months post-intervention, 80.6% of Black children in START remained free of out-of-home placement and child abuse and neglect. And this was only true for 56% of Black children in traditional child welfare services. We also learned that once they were involved in START, there was no evidence of racial disparities in the services provided or the outcomes. So this is super important, and we're working on this with our affiliates to make sure that there's equal access and equal treatment. So I can talk a lot more about that later, but just wanted to really let you know that was an important finding for us. We also found cost savings. So for every dollar we spent on Kentucky START, we saved $2.22 just in the offset of foster care costs. And we know when families enter recovery, there are many more cost savings that come with that. So as you can see, as a high-level overview, we've been building the evidence base for this model for a very long time, and we continue to study the model. So when the START model is implemented with fidelity, these are the outcomes that jurisdictions can expect to have. And because of this, START is listed as a promising practice on the California Evidence-Based Clearinghouse for Child Welfare, and it's a supported practice on the Title IV Prevention Services Clearinghouse. And what that means is that states have the ability to draw down federal Title IV prevention dollars to support and sustain the model. Where is START located? We're in 8 states so far: Kansas, Kentucky, Maryland, North Carolina, Ohio, West Virginia, New York, and now Nevada. Washoe County has signed on. Lisa Lee. We are very excited to be working in Nevada, and we're just getting started in our work. And just some things for you to consider. I always like to leave communities with implementation considerations, and I have pages of them, but I'm going to give you a few, just a couple since I'm about out of time. So really, I always ask jurisdictions, what's the goal you're trying to achieve, and to start the model to help you do that. Our model is very, very effective at keeping children in the home and not letting them go to foster care. We're very effective in engaging parents into treatment. So there's a lot there to chew on. And we say, look at your data always. Do you have enough families that actually need the service? Site selection, rural versus urban. It's been tested in both, and the outcomes are good in both. The difference is implementation goes much quicker in an urban setting because usually there's more available resources. Not saying there aren't issues and barriers, but that's usually the case. Started in an urban center. We can do this in a rural site. It just takes longer to build the treatment array of services and to reach model fidelity. So it does take longer. And so there are lots of considerations underneath both of those that if you're interested, I can go into it another time. You got to consider capacity to implement. And right now, workforce is one of the most important things to consider. As you know, nationwide, child welfare is seeing the worst workforce crisis we've ever seen in our time. And so that's something to consider. Community context, what's going on in the community? Is the community ready to accept something like this? What about collaborative relationships with providers, judges, and other family serving systems and agencies? Those are things to consider. Leadership. I always say leadership is really, really critical at both the state and local level, in both treatment, child welfare, and all the partners. And what we want to know is, are they supportive? Are they willing to put in the time and effort? Are they willing to assign staff to do the work? Is there a willingness to try to do something different? And then is there funding? And the funding sources are, Title IV, CAPTA, Block grants, SOAR funds, VOCA funds, COVID relief funds. There's all kinds of different funds states are using. So that's a consideration. And then I just want to leave you with what we call the spirit of START. And this is my favorite thing ever. In START, we approach substance use disorders with compassion, understanding, and hope for recovery. We work as a team, supporting and holding each other accountable. We believe in family, love, equity, and redemption. And that is my quickest start presentation ever. Did you catch that? I can really talk, right? I can talk. All right, that's what I have for you today.
Fantastic. Thank you for your presentation. And the handouts, actually the START handouts are posted on the Attorney General's webpage. So does anyone have questions for Ms. Wilhauer from our subcommittee members? Any questions?
Madam Chair, Ms. Lee does.
I Chair recognize Ms. Lee. Thank you.
Thank you, Madam Chair. You know, I was going to say something. I am so excited that you're here, Tina. I'm so excited about START. As many of you know, I was on the other side of the child welfare system, involved with families in medication-assisted treatment, specifically medications for opioid use disorder, and experienced those challenges right along with the families as they butted up against a system that wasn't compassionate or loving towards their towards the fact that recovery is a complicated and often nonlinear process. And so, and this is the topic of my dissertation, super passionate about keeping families together and wrapping services around families that are struggling with substance use issues. And I'm so excited to implement this in Washoe County, now being on this side of the child welfare system and having the capacity to help kind of steer some changes as our system is really crumbling due to the amount of substance use in our community. If you look at the data in Washoe County versus Clark County and even statewide, our child removals due to parental substance use are way higher than, you know, like I said, the state and other parts of our state. So I'm really, really happy to implement this. And I'm just so excited every time I hear you talk about it. So thank you so much.
Very
Thank
excited,
you.
Lisa.
Madam Chair, Mr. Shell has his hand raised.
And Chair recognizes Mr. Shell.
Thank you, Madam Chair. This is Steve Shell for the record. I just wanted to mention, Ms. Wilhauer, I'm very impressed with what you presented here today. The system I work with in Northern Nevada has a children's hospital, and I would really like to meet with you and Lisa separately one day soon. So I just wanted to mention that. But great work. Thank you.
Thank you. Happy to meet whenever, and I'll wait to hear from you and or Lisa.
Great. Thank you.
Any additional questions? Okay, I just have just one, Ms. Wilhauer. When you were speaking about the data and you made mention that our African American families, is it families or just individual?
Families.
Families?
Yes.
It's 86%.
80.6% of Black children in START, which their families, remain free of both out-of-home placement and child abuse and neglect after 12 months after the case being closed. This was only true for 56% of the families who were in traditional child welfare services.
Okay, and your data, does it break it down for each ethnicity, you know, each, Black, brown, indigenous, and white? It doesn't break it down. It just zeroed in on.
Right. This study was just with African American families. I live in Kentucky, and so we are a very rural state with only a couple urban centers, and we did not have enough families of any other ethnicity. We didn't have enough to enter into that study. Some Hispanic families, but not enough. So we really wanted to focus on the subgroup of African Americans. I will tell you that we are about to start working with a tribal population in Montana, and we are looking forward to testing it in an indigenous population as well.
Okay, all right, thank you. Thank you so much. And thank you for your presentation again.
Thank you.
We appreciate your time. Next, we'll have to hear from the Honorable Chief Judge Lynn K. Simons. And welcome, Chief Judge Simons. I appreciate your time that you've given us today. Knowing your commitment to children and ensuring families' recovery and access to treatment, and now in your current role as Chief Judge, we are pleased to have you here to provide any observations about the unmet needs for the persons involved in the justice system, gaps in treatment services, and any recommendations you would provide this subcommittee. And thank you, Chief Judge.
Thank you, Madam Chairperson. And also, I reviewed the appointments of this working group, and the participants are simply remarkable, and I have the greatest respect for you. And I am heartened by the fact that there is a spotlight shining on this area because it affects us every single day. I'm talking to you today not only as the Chief Judge, which is over both family division and general jurisdiction, but also I'm our specialty court liaison. And I'm also one of the sitting judges on a newly developed track, which is the young offender track. And I'd like to speak to you with a voice from all three. The mission of our specialty courts is to improve the quality of life, reduce recidivism, and increase community safety and awareness by engaging the substance abusing offender, or in particular, those offenders with mental health illness with an intensive court supervised treatment program. It happens through a myriad of phenomenal individuals. There are defense and prosecution counsel, court officers, treatment providers, parole and probation officers, and drug testing staff. And of course, court clerk and the judge. We have 8 specialty courts currently. Our numbers have ranged to last year were approximately 376, down from 741 the year before. A lot of that is attributed to COVID and to access. We were very nimble, and part of our message as our court and mine as a leader of our court is that we must be nimble. It isn't just about pivoting during COVID or it's about meeting challenges with nimbleness. And I have to proudly say that our court did, because we immediately switched to Zoom. There are arguments that it's not as effective. There are arguments that it's a tremendous benefit to those that are working, that they don't need to miss an entire day to come to court. The issues, I think, highlighted by Ms. Willauer are clear, that so much of this happens as a genesis from a person's life when they are a child. And they come to me and they come to our court, and you see a person with no criminal history and they appear in front of me for sentencing. Do I put them on probation with no treatment, hope they succeed? Do I, if it is serious enough, put them in prison with no treatment, where arguably they may learn to be more criminal activity bound? Or do we consider it an intervention? What the overarching is meeting the needs of this remarkable group, starting from adult drug court, which is really the court with the least amount of restrictions to get in. And our court has evolved not only in programs, but in the judging. Best practices would say that you have one judge do your specialty courts. The numbers just preclude it to get the correct and diving deep with participants. We used to have, our court was 3 months on with a judge, then to another senior judge, and that was the purported answer to continuity. When our chief judge that was doing most of the calendars retired, we split it up amongst the rest of us. And we do our specialty court dockets, which some range from 4 to 6 hours a week on top of our other work. It is a passion of the heart for me to do it. And so we look at our courts: mental health court, veterans court, felony DUI court, adult drug court, medication assisted treatment court, the new track of young offender court, prison reentry court, and family treatment court. These have evolved, and I'm going to give you an example. We had a youth offender court, which was primarily opioid addicted persons, and from an age group from 18 to 24. It was highly restricted by the funding, and it became too challenging to meet the requirements for funding. And we folded it into our medication assisted treatment court, which Judge Freeman sits on, and I believe you've heard from him. And it worked beautifully. But it seemed that there was this young population that really need to be treated differently. And so we created, through a lot of work, the young offender court, and it can be any substance. It's not because we have in our community a real resurgence of meth and cocaine. And so it's not typical to some areas in our country that are so opioid driven. And so this court can address any type of addiction. And in fact, yesterday in the sentencing, I referred somebody who has a Xanax addiction. And so as part of this court, we have strict milestones of what they need to do and accomplish through the program. Each one of our courts is that way. We have treatment providers that we partner with. We have a designated probation officer that really understands these different populations. For instance, also on our Veterans Court, we have somebody who was a veteran, sits on that court. We look at what the needs are. And so, for instance, for young offender, we provide a more global, we even get them help with birth control, with medical, with dental, things that that population from 18 to 27 usually engages in high-risk behaviors, in addition to whatever method by which they're ingesting their substances. And so we address that. We help them along with education. We partner with Join to provide assessments, classes in budgeting, time management, and et cetera, and give them even ideas for employment. At the right time, we have them employed because the costs they have to pay are significant. And for instance, I'm going to give you a practical example. I just adore my population of young offenders. I think half the time I'm momming them because they weren't mommed, because when they were younger, they didn't have access to treatment. And my goal is, one, to affirm their sobriety, two, to give them sandwich approach on discussion, positive, negative, positive, to give out the consequences, because we have them. They involve either writing an essay on missing tests, diluted tests, writing apology notes, community service, which now this crowd is talking amongst themselves. They don't want to do it because it involves shoveling a vast amount of manure.
Is this going to bug you too much?
No, I'm just.
And so the part of the program, for instance, with them, I was talking to one fellow and I said, "You're missing too many appointments. How are you keeping track of them?" He says, "Oh, I keep track of them in my head." And I said, "Well, how's that working for you?" And they said, "It's not at all." So we bought planners, we give them planners, and they're kind of simple things that you and I take for granted, but that they haven't been taught. If they do miss classes, we send or they miss counseling or something, we send them to a time management class. And then inevitably I have one that says they didn't have time to go. So we deal with that. It is a remarkable use of taxpayer money in a positive way. There isn't enough. I'll give you an example of our mental health court. We have over 50 participants and we receive $17,000 for that court. And so we have to turn away a lot because we can't provide the services. Originally, the funding committee, which I also sit on, based its funding by community population and not by participant population. And so I've been getting into the ear of several saying we really need to look hard at participant funding based on those numbers, because we have some in the rurals that are underfunded. We are underfunded. And it is a shame to turn anyone away because of funding. We are evolving in the sense too, not only with different judges handling different courts, but taking a look at needs for new courts. Not just, we usually start them as a track before we can get our own funding. We're taking a hard look at multiple felonies. We have young people that collect felonies. They don't realize how deeply it'll affect their life in the long run. And then when they have some, they finally, maybe around 40 or 50, are tired. And that may be the right time for their intervention, but we don't want to preclude them because they have multiple felonies if they are not preclusive felonies of violence. I'm looking hard right now at a court for persons that have been recovered from sex trafficking. Because oftentimes we see that then they join the criminal justice system because they have no other avenue. There's really lacking treatment for this population as we recover them. In addition, of course, there's, as much as we try to separate mental health issues from substance use disorder, it is overlapping at every turn. And one of my personal goals is to really try to utilize our detention centers to do some of our basic treatment. It's a captured audience. It would be a wonderful use of monies statewide if we had more treatment in our jail, or even just a substance, really kind of a drug unit, and or they have a mental health unit. And frankly, that is a call, a beacon for treatment prisons, because there are people that, especially DUIs, that my only choice is to send them to prison, but they go with no treatment, and they could be actually specialized. And like I said, the food's there, the bed's there, there's staffing there. We just need to add counseling. What is highly successful with all of our courts is individual counseling and group counseling, and then any additional meetings and the testing. And I think that the thing that I try to do is I try to connect with them. And I know Ms. Wilhauer will understand this, that with the younger crowd, you just want to find one thing that's important to them. I have helped somebody through having to put their dog to sleep. I have helped somebody who was a soccer player with a scholarship that lost it and now is playing adult soccer. I have people that are taking tasks to increase their vocational, and they're just proud. And I tell them that I'm proud. We give them a rock that says, be brave, be bold, be you, when they graduate. And we let them have it as a touchstone. We actively seek out community partnerships. We have just hired a new specialty court manager who really comes to us with a lot of grant writing, because that's a hard reality. We try to provide collaborative. We do try to collaborate with other courts. We take a hard look at if there's redundant services. We help them with applications to inpatient programs. We follow what the legislature enacted with regard to what is required to participate in the specialty courts, and we use all of the evaluations. We find that the statistics for use, particularly in younger people, the use of alcohol is higher in Washoe County compared to the rest of Nevada in all middle school and high school students and adults. In addition, the use of marijuana and marijuana derivative products has doubled. In 2020, 36.9% of University of Nevada Reno college students reported using marijuana in the past 3 months. 31% of high school students perceive that there's no risk to marijuana once or twice a week. Our programs do not allow them to use marijuana. So not only does the jail become forced sobriety, but also our program supports that. The rate of drug-related emergency department encounters has been higher in Washoe County compared to Nevada every year. And so where do they go? They go to the jail. They're young. One person I sentenced was 18 years old. Is that the right place? No. Is it the right place for that veteran that suffers tremendously from PTSD because of the horrific things that that veteran saw at a young age in one of his or her tours, and then has numbed themselves by substances? Is prison right? No. So through, I have to say, just remarkably dedicated staff, we have successful completions. I absolutely loved what Miss Lee said regarding that recovery is a non-linear process. And she is absolutely right. And so what does that mean? That means as a court, we have to be as linear as we are. We have to be non-linear, and we have to have our finger on the pulse of what the greatest needs are, where we can help, where we can intervene, where we can pick up these people and say, look, you've got to get Medicaid. Look, we're going to help you with all your applications. We are going to give you a planner so you can meet your meetings and you can thrive. And I have to tell you that when they have a success and we congratulate them at any age in any program, they are so proud of that graduation and what they've accomplished along the way. And so we're very grateful to the monies that come to the court from its various avenues. I cannot emphasize enough that we need more, and that we want to partner with our legislature and all treatment providers to provide information on how we can continue to really reach in, almost like the claw in Toy Story, and pull people out of the criminal justice system, show them another way, show them we care, because it's a huge part of it, just looking them in the eye. At the end of every hearing, I say, it was really nice to see you today, Mr. So-and-so. I look forward to seeing you next week. That simple thing, they come back because I say that. And so, as I said, as a chief, I'm always navigating how we effectively manage our criminal dockets, how I parse them out to other judges to handle them. As a liaison in the specialty courts, I keep my finger on the needs of all the courts. And as a sitting judge on a specialty court, my boots are on the ground. I'm there with them. I can tell you that it is very successful and it needs to expand. And we're grateful for any collaboration and participation. And again, I'm so thrilled that this body is shining a spotlight on this need from so many different lenses. Any questions?
Well, thank you, Chief Judge Simons. And we will ask the subcommittee if there are members, if there are any questions of the Chief Judge. I see Dr. Dixon's hand raised. Dr. Dixon?
Right. Yeah, thank you. Yeah, Leslie Dixon. You've talked a little bit about funding. Where do the courts get their funding?
So we have, well, the court as a whole, Washoe County is funded through Washoe County budgetary process as a separate branch of the government, but still monies are provided. For purposes of specialty court, we receive it through the Specialty Court Funding Committee. It is a committee that is born out of the AOC and the Supreme Court. Justice Lydia Stiglitz is the chair. And there's a certain amount of monies that are allocated every year. And recommendations are made both from fee and general fund allocations from the state. I'll give you an example. We requested, we requested for mental health court $260,000 and we received $17,000. There's a very small pie to divide up for very great needs. And so it comes from primarily from those two sources. We do receive some backfill from the county.
So, you mentioned several different places. How much money do you get from the state general fund?
So the state general fund, for instance, fiscal year 23, general fund allocations that are approved for our courts are $260,000. of our total. Our total is over 700,000 that we receive.
So do
So
you,
fee-based is the other side, fee funding.
right, so do you have plans to ask for more money from the legislature, from the state?
We are hopeful to do that. I think we have to change the model of how the funding is provided and give the state more avenues to provide funding. I will not, as part of the second judicial specifically, but the state funding committee will. And then, of course, it's the dynamics of the different regions asking for money and having different needs, because, for instance, what might be needed in Lovelock with one judge and maybe one heavier court has a different need than we do if we're trying to treat mental health.
Okay, any additional questions from Dr. Dixon?
No, not for me.
Thank you.
Thank you. And Chair recognizes Ms. Lee.
Thank you, Madam Chair. Lisa Lee for the record. Thank you so much, Judge Simons, for that presentation. It's really great to see the justice system be more compassionate towards people. It's definitely a lot different than my experience over 20 years ago with the justice system. I have two questions for you. One is, it sounds like you're in Washoe County, Second Judicial. I'm wondering, you mentioned something about the jail. They do have a narcotic treatment program, which is, yeah. And so I just wanted to have that on public record that they do offer 3 types of medication assisted treatment: methadone, buprenorphine, and naltrexone, that they can initiate or maintain someone's treatment while they are incarcerated up at our local jail. So that is awesome. Lots and lots of gratitude from me to our entire leadership staff at the Sheriff's Office for putting that together. I think that they're really doing some awesome things within our jail up here, and hopefully that will be modeled across the state. So I do think that they are doing a certain amount of substance use counseling and treatment.
It's primarily medication, not as much counseling at this juncture. It's primarily medication counseling with some classes offered. And I can tell you that Sheriff Balaam is totally open to suggestions to increase the amount of persons in the jail that are on medication currently, either related to mental health or other reasons, is so high. It's shocking. And we were happy that they would start to provide some medication assistance, because it helps us when people get to us in our specialty court. And I think you may have another question, but before I just realized I forgot to suggest something, and that is this: because we're on Zoom, you can watch any one of our courts. For instance, my staffing is at 1:30 on Wednesdays. I see my participants at 2:30. We have, you can see them on our court docket. You can watch adult drug court, felony DUI court. There's you basically one every day, Monday through Thursday, and I urge you to watch. It's a very different court. It's a therapeutic court, and it is exactly what you said, Ms. Lee. It's compassionate.
Thank you so much. I did participate for many, many years with clients, every week, going to court with them for years in many of those courts, and cried every single, I will say, I cried every single time, because what I witnessed there in the graduations, I mean, I was just like rooting for all of them, and seeing that kindness extended from the bench, where they're just real people with the participants, and celebratory and encouraging. It was really heartwarming. So I suggest anybody who's having a bad day to go check out one of those court proceedings to really hype up your hope. Mm-hmm. My other question for you is, you mentioned meetings, and it's been my experience that many courts kind of push people into 12-step recovery meetings, which based on the data, are not necessarily the gold standard of community-based recovery supports. And so I think the data really, and peer support, right? There's this whole recovery movement, and me as a person in long-term recovery, part of that movement, there's a movement for multiple recovery pathways. And we're fortunate here in our community, and because of Zoom, that we have access to so many different recovery paths: smart recovery, refuge recovery, white bison. I mean, you name it. There's a plethora of recovery pathways open to people. I'm just wondering, how open are the courts to adopting multiple pathways?
So we, and I use the term meeting because we direct them to what we call self-care meetings. And we will often let them provide we give them all sorts of options: Zoom, 12-step, traditional. We find some people really want to go in person, and I talk to them about, have you met one that are you participating in one that you feel comfortable with? Because you want to try other avenues. We approve all types of self-care meetings, and we're extremely open to it. My team particularly, because you just don't know what will speak to that 18 to 27-year-old. And it may be something completely different that speaks to the veteran. And so, and it's kind of interesting because they really make me laugh sometimes as their initiative. When they think that these participants don't have it, they'll come in and say, well, Judge, I really want to participate in this. And we always have the staff look at it, and I have them make a proposal, and 9 times out of 10 it's granted. And we've done a couple of very creative self-care allowances recently, and it was great how it was presented, and it connected with them. And so very open, absolutely, and welcome any suggestions. I want this court to continue to thrive. And so as the chief judge, I'm very open-minded I'm just not one of those people that we always did it this way, so we have to do it this way. I think that the impact in so many areas of our life from substance abuse is way beyond what used to be the just don't use mantra of yesteryear and go do something 12-steppy. It is so much more complex, and there's so many areas that we can engage in, like telling somebody, oh, you have a bank account for the first time in your life. They're whizzes at, writing checks on other people's bank accounts, which, we stop, but, really commending them, like, good for you. And we're going to send you to this budgeting. I have a person who is now a manager at a McDonald's, and he's fantastic at it. And he is young, engaged, loves it, and has a bright future, and never thought he did. He would be the first to admit he'd rather go in and rip something off from McDonald's than actually do the work and connect. The other thing I also really ask of this population is to pay it forward if they get an opportunity.
Thank you so much. Thank you.
And thank you, Chief Judge Simons. We really do appreciate your presentation, and I think that that's it for our presentations for our experts. And I want to thank both Ms. Willauer and Chief Judge Simons. This was perfect. Thank you.
Thank you to all of you. It's an honor, and I appreciate your engagement.
Thank you.
Thanks, everyone.
Okay, we have more subcommittee business to attend to. We'll go to agenda item number 5, which is review process for prioritizing recommendations. So the next slide is an overview of our recent timeline, which has brought us to finalizing our priorities today to present to the SURG committee in October. So this is the timeline we have been working from for the past 3 months. As you see in bold, today we shall finalize the first subcommittee recommendations for SURG, which will be presented to the full committee in October the 3rd. We are currently focused on 5 main priorities. We will have a chance to discuss them and any other priorities during this next agenda item. Discussion and motions to refine and finalize our top recommendations will occur in today's meeting and be presented to the SURG along with the other subcommittees' recommendations. The October SURG meeting will provide a foundation for the annual report, which is due in January, and will include recommendations that are significantly specific and actionable and approved by the SURG. Next slide, please. Other subcommittees have added recommendations and re-rated recommendations following presentations. We have continued with our original slate of recommendations and worked to refine them. Today, we will discuss and refine motions and take action to finalize our slate of recommendations to the full SURG committee on October 3rd. Are there any questions before we proceed? Kelly, I see a hand raised. No?
I don't
Okay.
see any questions, Madam Chair.
All right, thank you. Okay, so agenda item number 6, subcommittee recommendations and finalized top 5 priorities. Weighted recommendations were presented in June. We reviewed them briefly in July and asked for additional input from the group. In August, we further refined recommendations with the understanding that we will bring only 5 to 7 recommendations forward to the SURG, not including harm reduction recommendations. Let's begin reviewing and finalizing our priority recommendation. I asked members to review the recommendations we have compiled to date and prior to this meeting. Each independently ranked their preliminary top 5 recommendations. In August, we discussed the MAT recommendations. Here you can see the original 3 bulleted recommendations and the August 12th summary of a combined recommendation. The subcommittee approved a motion to collapse these 3 recommendations in August. Are there further changes or revisions for this recommendation? Okay, I don't hear any amendments that anyone wants to come forward with. So do we have a motion to approve? Dr. Dixon?
Yeah, I'm going to make a motion. I just want to say that I was on the Bridge Committee meeting yesterday, and I mentioned that this was going to be one of our priorities to support Bridge. So yeah, I will move to accept this as our #1 priority.
Okay. Thank you, Dr. Dixon. Do we have a second? Ms. Lee, second.
Thank you, Madam Chair.
All in favor signify by raising hands or saying yes.
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 Any opposed? Any abstentions? Motion passes. All right, we have our first one. Okay, and this is our second recommendation. Are there any revisions needed to this recommendation?
I am going to ask a question. Is just saying lived experience enough, or does that term need to be expanded upon a little bit?
All right, committee members, Dr. Dixon has a question on the floor, please. Anyone want to expand on it, or if you think that that engage individuals with lived experience is enough, or if Dr. Dixon wants, if you want to expand on the recommendation. All right, the chair recognizes Lisa Lee.
Thank you, Madam Chair. Lisa Lee, for the record. As a person with lived experience, I think that it's sufficient. I think the language, it sums up exactly what you're talking about, that people with lived experience, experiential learning. And I love this recommendation. I think nothing about us without us. And so people with lived experience should always be at the table, and the people closest to the issue are closest to the solution.
Great. All right, so any further discussion? Right, so do we have a motion related to moving this recommendation forward to the SURG committee in October?
Hi, this is Chelsea.
Madam,
Let me make that motion.
I'm sorry, that was was that Dr. Dixon?
No, this is Chelsea.
Oh, I'm sorry. Chelsea made the motion, and do we have a second?
Madam Chair, I'll jump on that second. Lisa Lee, for the record.
Thank you. So all in favor, please signify either by raised hand or saying yes.
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 Great. Any opposed? Signify by the same response. Any abstentions? Motion passes. Thank you. Next slide, please. Thank you. Our third recommendation was revised and approved by the subcommittee at the August meeting. Are there any revisions needed to this recommendation? And we're open for discussion. Any thoughts? If not, do we have a motion regarding moving this recommendation forward to the SURG in October?
Madam Chair, this is Steve Shell. I make a motion that we move this recommendation forward.
Thank you, Mrs. Shell. Second?
I'll second it, Dr. Dixon.
Thank you, Dr. Dixon. We have a second. All in favor, please signify by raised hands or yes.
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 Thank you. Any opposed? Any abstentions? Motion passes. Next slide, please. On this slide, you see recommendations again related to workforce. We asked if Dr. Woodard would provide guidance to the subcommittee on how to better define radical changes. The link provided below and posted as an attachment contains suggestions from regional behavioral health policy boards and the Behavioral Health Commission related to workforce changes. This was suggested by Dr. Woodard as a resource for the subcommittee. Kelly, can we initiate that?
Madam Chair, would you like me to bring up the document for the committee to review?
Yes, ma'am. Thank you.
So Madam Chair, this is the draft, a letter to Governor Sisolak. It includes recommendations from regional behavioral health policy boards. I highlighted 2 recommendations. One was from the Northern Board. They supported a tiered approach for a calibrated mental health system, including robust relationship between clinicians, community health workers, and peer support specialists. Following this model, the Northern Board explored strategies to increase the clinical workforce and expand the use of both community health workers and peer support specialists to bridge the gap caused by lack of clinical providers. Their recommendations included supporting local agencies, facilitating CHWs and PRSS workforce development, expanding Medicaid reimbursement to include all behavioral health clinicians as community health worker supervisors, providing incentives for providers in rural areas, evaluating network adequacy and efficiency for insurance company credentialing, supporting family caregivers through access to reimbursement, respite services, and training across the lifespan. So this document includes that recommendation. It further includes a recommendation from the Clark County Regional Behavioral Health Policy Board. And those are also highlighted on this document. So for the Department of Health and Human Services and the Division of Public and Behavioral Health to review the allocation of funds to meet the identified needs of the Clark region, address the region's counselor to patient ratio by attracting counselors from out of state, mainstream the application process for a behavioral health professional to become licensed. Again, that recommendation of reviewing the Medicaid reimbursement rate and processing time, that's an addition, to align with more competitive states. And then again, to add incentives for providers who serve high-risk populations and utilize peer support specialists. So those 2 specific recommendations were brought forward. And then the third component that I would highlight is the workforce actual recommendation from the commission. And so the board said that they felt that another solution that might be more feasible is the boards aligning their guidelines to make the licensing of new providers more streamlined. If the process for licensure is easier to navigate, it's more likely to attract providers in our state. They provided an example. They said Nevada's various boards of examiners should be sharing strategies to encourage and develop a licensed behavioral health workforce. And they saw the biggest opportunity for collaborating across the boards in areas of license reciprocity with providers moving to Nevada from out of state and supervision on new professionals seeking licensure in Nevada. Regarding reciprocity, they felt that Nevada is going to continue to struggle with behavioral health workforce unless they make the process easier for fully licensed and experienced providers moving from out of state to obtain a license. And then they provide some rationale for that. They also noted that there are several interstate compacts for licensing reciprocity in various behavioral health fields that Nevada should consider joining to increase the number of providers. And regarding supervision, they said there are two opportunities in Nevada to improve access to new providers. First is to standardize the training process to become a supervisor in a given discipline, and noted some of the challenges with that. And the other was, another innovative suggestion was the use of telesupervision. They described the advantages of that. They said the state licensing boards are the appropriate regulators to oversee and develop these services, and felt that around the world, telesupervision services are being developed and implemented. This is also known as e-supervision, and it's defined as the use of video conferencing technologies to supervise grad students or assistants remotely. So then it goes on to just describe telesupervision in more detail. So clearly there's a number of things to unpackage in here. And you know, one recommendation from Dr. Woodard, who was not able to participate today, but pointed the subcommittee towards this document, is to see if you wanted to maybe qualify the radical changes piece by then referencing this document as a support, if it is inclusive sufficiently of the will of this subcommittee. And with that summary, I would note that Ms. Lee has her hand raised, and I am going to stop sharing this and go back to the recommendation so that people can see what that is.
And Chair recognizes Ms. Lee.
Kelly, thank you for, and thank you, Madam Chair, Lisa Lee for the record. Kelly, thank you for showing us that document. I believe the verbiage within that document, I was waiting for the reciprocity piece, but I believe that those are most of the things that we talked about when we started thinking through and teasing apart what radical changes could mean. So based on that, it sounds like being creative around reimbursements, higher Medicaid reimbursements, which is like the bane of every provider's existence in the state of Nevada. We have horrible Medicaid reimbursements in this state. It looked like there were some special features around CHWs and PRSSs, and then reciprocity, and then being strategic around streamlining supervision, including the use of telesupervision. I'm wondering if there's an opportunity to refine the language with this to be more meaningful. I'm just uncomfortable around radical changes without that specificity piece. And that's just how my brain works. I need specific language because radical changes to me could mean, you know, universal health care, right? But it might not mean that to someone else. And so I think when we're making a recommendation, it's useful to have very, very, like, you know, I don't know, I just lost my train of thought, but we need specific language that addresses what we are trying to say. I just think radical changes I'm uncomfortable with. It's really broad. And like I said, it could mean we're recommending to DHHS that they adopt universal health care, and you know, who knows what radical changes mean. So I would be more comfortable with adopting the specificity of the language used in the document we just reviewed. Thank you.
Any additional
Dr.
discussion?
Dixon?
Chair recognizes Dr. Dixon.
Yeah, I'm going to agree. The word radical just has so many meanings that are unpleasant to some people that I don't like the word there. But, you know, I think we're talking more like the concept of significant instead of, you know, versus minimal, and but radical is is a very politicized word. So we need a new word.
Well, we could use progressive.
Well, that's not so bad.
Any additional conversation, discussion?
Chelsea Cheatham.
Chair recognizes Ms. Cheatham.
Yes, I agree with Lisa Lee that we should be really specific in what we're saying here. I like the idea of referencing the letter, but I think if we put some of those recommendations in the wording with this recommendation, some of the recommendations from the letter in this wording, I think it'll make it a little bit easier for people to understand what we are looking to change here.
So Madam Chair, I'm hearing two things. One is to reference the letter and then to provide specific examples. So I can give an attempt to craft something and have the subcommittee respond to it. So I wonder if we even need the word radical or significant or progressive. And maybe instead of consider, the word is implement. Right, the recommendation is to implement changes to recruitment, retention, and compensation of state frontline health care workers and enhance compensation in alignment with the board, and we would reference the specific board. So it's the Behavioral Health Commission's or the Commission on Behavioral Health Board's letter to the governor of June 22nd. Specifically including evaluating and pursuing higher Medicaid reimbursement, greater use and scope for community health workers and peer recovery support specialists, expanding reciprocity and streamlining processes to attain reciprocity, and implementing telesupervision or e-supervision.
Okay, thank you, Kelly. I think that works for me. I think it highlighted everything that was covered within the letter that Dr. Woodard suggested. So any discussion? Do we want to think about it? Okay, committee members. How do we feel about it? Chair recognizes Ms. Cheatham.
Yes, I think what Kelly just read, I think that kind of covers a lot of the changes that could be made to this to make it more specific. I like it.
Okay. All right, I'm going to call on each one of you individually. Ms. Lee?
Madam Chair, one moment. Mr. Shell has raised his hand.
Okay.
Thank you, Kelly. And Madam Chair, this is Steve Shell for the record. I was just going to add that I totally support with the way Kelly just read the proposed changes to the recommendation. I'm in full support of that. So thank you.
Thank you, Mr. Shell. And Ms. Lee?
Looking for my unmute. Sorry about that. Yes, I am in full support of that language change as well.
And Dr. Dixon?
Yes, I think that's good.
Okay. All right, so we will ask in reference to the new language. So do we have an emotion for an amended recommendation to approve?
Madam Chair, this is Steve Shell. I make a motion that we move forward with the recommendation based upon the amended language changes.
Thank you, Mrs. Shell. And do we have a second?
Yeah, I'll second it, Dr. Dixon.
Thank you, Dr. Dixon. All in favor?
Yes.
Yes.
Thank
Aye.
you.
Yes.
And any opposed? Any abstentions? Motion passes. Thank you. Okay. And this fifth recommendation from the subcommittee, is there any discussion in reference to this revised recommendation? And I believe this one had a lot to do with Ms. Lee, that brought our attention to some specifics in here.
Madam Chair, Ms. Lee has her hand raised.
Chair recognizes Ms. Lee.
Thank you, Madam Chair. Lisa Lee for the record. I just wanted to say that this goes with a recently published article that Sean Thomas and others wrote. It was just published in MMR Weekly regarding our data in Nevada looking at 2019 and 2020, especially looking at Hispanic young males. And the rate of overdose has increased. I can't even remember. It was like 164% or something. Don't quote me on that. Read the article. But it's really, really increased in this population. And I just think it speaks to being able to get that outreach out there to communities that are disproportionately impacted by fatal drug poisonings and overdose. And I think it also speaks to the fact that that's not happening currently. And it needs to happen. So I'm really comfortable with this recommendation and feel like it aligns with being in a data-informed body.
Thank you, Ms. Lee. All right, so do we have a motion to approve?
This is Dr. Dixon. I'm not going to move to approve it. It seems to me that this really should be coming out of the prevention subcommittee.
Okay, I can see the verbiage here with the overdose prevention supplies. Is that what you are?
Right. In fact, there was something you read earlier about, that we're supposed to focus on treatment, and this is overdose prevention. There's nothing in here about treatment, so we could maybe put treatment in and make it ours, but right now it's all prevention.
Let's discuss that.
Madam Chair, Ms. Lee has her hand raised, but Kelly Marshall, for the record, I just want to reinforce that this is the treatment and recovery. And so it's not exclusive to treatment. It also includes recovery as a subcommittee. And again, I would note Ms. Lee has her hand.
And Chair recognizes Ms. Lee.
Thank you, Madam Chair. I was just about to say that, Kelly, that this is also treatment and recovery. And I can tell you that I wouldn't be here today without many, many opioid overdose reversals. And so I personally feel that there is no opportunity to recover when you are dead. And so I don't know if that's prevention or if it's recovery, but to me, it's imperative that we keep people alive so that opportunity to recover, whatever that looks like for an individual, is available. So that's my spiel on the importance of this to the recovery conversation in particular.
Madam Chair, Kelly Marshall for the record. If I may I suggest that Ms. Cheatham just share some of her work in terms of distribution as a pathway towards recovery.
Chair, right. Thank you, Ms. Kelly, Ms. Marshall. Chair does recognize Ms. Cheatham.
Sure. So previously, I worked exclusively in the harm reduction space. So I worked for Track B Exchange, Impact Exchange, and in that role, we distributed overdose prevention supplies, including naloxone, fentanyl test strips. We also distributed other drug testing supplies and had a mass spec machine where we were able to test supplies for people. And I think those anything related to harm reduction is can be used as an inroad to get people interested in treatment. And when they're interested, they're able to come to an organization that's able to offer these supplies because it's a comfortable place for them. And then also it allows people to stay alive, as Lee said. Harm reduction and in the provision of overdose prevention related items is really right now, especially in the world with so much fentanyl, it's really the way that we're able to help keep people alive so that they can get into treatment and get into recovery.
So why can't we just add something like, in order to facilitate entry into treatment, we recommend all this?
I like that verbiage also.
So Dr. Kelly Marshall, for the record, Dr. Dixon, if we were to rewrite number 5 to say to facilitate entree into treatment and recovery, comma, ensure the BIPOC communities are receiving overdose prevention, etc. Does that capture your thought?
Right.
Well, thank you. Glad we had discussion today. All right. So do we have a motion to approve the amended language for item number 5, recommendation?
Hi, this is Chelsea. I will make that motion.
Thank you. And do we have a second?
I'll second it.
Thank you, Dr. Dixon. So all in favor, please signify by either yes or raise hand.
Yes.
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 Any opposed? Any abstentions? Motion passes. Thank you. Okay. Here are other weighted recommendations in this next slide. We have reviewed since July. We have an allowance for up to 2 or more recommendations, which could come from the other weighted recommendations on this and the following slide, or you could potentially add a recommendation from previous presentations. Like today's presentation, for example, implement in Nevada a specialized child welfare service delivery model that improves outcomes for children and families affected by parental substance use and child maltreatment. Or we can move forward with the 5 recommendations we have. Is there any discussion? Would you like to include Ms. Tina Willauer's presentation? Or are we satisfied with the 5 that we want to push forward in the October 3rd SURG committee meeting?
Madam Chair, Ms. Lee has her hand raised.
Chair recognizes Ms. Lee.
Thank you, Madam Chair, and apologies for raising my hand so much. I personally would love to see more support for families that are impacted by substance use. I feel like that's so many people across our state, and that there really aren't enough supports to ensure that that intergenerational cycle has a chance to break, that there are chain breakers. And instead, what we see is that cycle perpetuated across generations. And that not only impacts families, but it impacts communities. Whether that be, you know, like little C community and big C community. And I think if we're really going to address, and maybe this goes into prevention, because for me, it really is about primary prevention and how do we kind of upend familial trauma patterns and wrap support and wrap protective factors to create resilient families and resilient communities. And maybe it is, you know, ensuring that families have access to an easy access and support to get into treatment and get into community-based recovery supports. And maybe that is something that we can do to disrupt interfamilial and intergenerational cycles and upend early childhood trauma, and do our part to really address ACEs. And so I would love to see that from this body. I'm not sure what the appetite is among other members.
Okay. All right, thank you. Any more discussion? Is any other discussion in regard to this weighted recommendation, these 3 bullets?
Madam Chair, Kelly Marshall, for the record, 2 points. One is I just wanted to note that we do have other weighted recommendations that we could cycle through and then come back to the discussion.
Okay.
And Dr. Dixon had her hand raised.
Chair recognizes Dr. Dixon.
It's a question. Are we, once we made these recommendations to the main SURG committee in a couple of weeks, are we going to continue on as a subcommittee or not? Is that the point? Is that the plan to continue as a subcommittee and for the next year? Yeah.
Yes, ma'am.
Okay. All right. So some of the stuff could wait till after the next SURG committee, right? Okay.
Madam Chair, Kelly Marshall for the record. If I may just provide context, since our team is supporting all of the subcommittees. Each subcommittee has gone through a slightly different process. They are bringing something like 5 to 7 recommendations, excluding harm reduction, for your consideration as a full body of the SURG on October 3rd. And then the chairs of each subcommittee will present their recommendations based on the actions you've taken. And then you will all deliberate as the SURG, as that larger body. If you recall from the very initial first meeting we had, the legislation outlines items A through Q. We are not able to, nor would it be possible to address everything in items A through Q through one report. And so the intention is that this body will continue to meet and actually is charged with annually studying and making recommendations.
Great, thank you, Kelly, for that clarification. All right, so we'll go to the next slide, and at the end, we'll have a more in-depth discussion, if you will. So this next slide, these are additional recommendations that was presented. And next slide, thank you. Based on previous reviewed recommendations and presentations, are there any other recommendations beyond the 5 that the subcommittee would like to bring forward in October? Remembering or recalling that we can only bring 5 to 7 recommendations, so excluding harm reduction. So we actually have 2 more if you want. If you're satisfied with the 5 for right now, that would be great too. So we know that there is a possible motion for Ms. Wilhauer's, from Ms. Wilhauer's presentation.
Madam
It's,
Chair, Ms. Lee has her hand raised.
Ms. Lee, Chair recognizes.
Thank you so much, Madam Chair. Can we go back 2 slides? There was a recommendation that was developed here, significantly increased capacity is needed for intensive care coordination to facilitate transitions and to divert youth at risk of higher level of care and or system involvement, support the mental health needs of youth in the child welfare system, fully support alternative funding and service delivery models for intensive care coordination. I believe with that bullet pointed suggestion from Dr. Freeman at GCFS that there is an opportunity to add in something about supporting families with who are screened into the child welfare service system with the factor of parental substance use, or something to that effect, like with parental substance use as a factor for child removal. I think there's an opportunity to sort of weave that within that recommendation from Dr. Freeman. Again, I'm not sure what the appetite is here, but I think what we don't have, at least in this part of the state, are many places for families to get recovery together. So for example, in Northern Nevada, we have step 2, which is for female identifying persons and their children to get treatment. And also there's an opportunity for transitional housing. And it's a great, great program. Another opportunity in Northern Nevada is the Women's Crossroads program. Again, female identifying persons with their children. Excluded in these programs are any kind of partners, however they identify in their family's orientation. There really isn't an opportunity for families to recover together and reunify with their children. And so that's been a traditional barrier to really not only reunifying children, but getting families to recover together. And so I think, at least for me, it would be awesome if we had that ability to sort of say, hey, we're prioritizing this. We see that this is a need in the state to offer more support for families, especially if they have system involvement and are at risk of losing their children. Because I can tell you, when people get their children removed, their substance use goes up, right? I mean, it's very traumatic, it's depressing. You just took like their most precious thing in their life away. And so seeing support around that would be amazing. And also for the kids that are really like caught in the crossfire of these systems. And so, again, I don't know the appetite here, but I think it's a solution, and I want to be part of that solution.
Okay, so we're looking at this bullet statement, and this, okay, could we, in a way, and I'm asking Kelly, combine that verbiage as suggested by Ms. Lee with the implement of the Nevada to specialized child welfare service delivery model?
So Kelly Marshall for the record. Madam Chair, I was trying to track Ms. Lee's language. But I think the question that you stated was, could we include Ms. Willauer's, the recommendation you stated previously as a potential for Ms. Willauer's. So if I look at that third bullet point, I think the recommendation is actually to increase capacity for intensive care coordination to facilitate transitions and divert youth at risk for a higher level of care or system involvement. And then you could go to implement a specialized child welfare service delivery model that improves outcomes for children and families affected by parental substance use and child maltreatment.
Okay. Any discussion? Because, you know, it only scored a 10 when we actually, you know, and this was one of the things that I was really concerned about also, that our youth, our families, you know, I wanted, for the treatment and recovery, it should be included in our scoring, I believe. Just a suggestion from me. So any discussion on the verbiage to include? So would this be our sixth recommendation to the committee during the October 3rd meeting? All in favor, please signify by either a yes or raise
Yes.
hand.
Madam Chair, do we need a motion?
I wanted to make sure that it's the discussion period. I
Oh,
want to make sure
got it.
everybody is there, you know, before we put a motion through. Okay, so yes, we'll ask for a motion for the amended language to approve a number 6 recommendation to the SURG committee for October 3rd. Do I have a motion?
Madam Chair, Lisa Lee for the record. I think Kelly nailed it with her verbiage that she read, and I would like to move to approve this bullet point with the amendments as the 6th recommendation.
Thank you. Do we have a second?
Madam Chair, this is Steve Shell. I will second.
Thank you, Mrs. Shell. And all in favor, please signify by yes or raised hand, please.
Yes.
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 Any opposed? Any abstentions? Motion passes. We have a 6. Thank you, Ms. Lee. And it's okay if you have questions and answers. Solutions is what we're doing here today. All right, next slide. Agenda item number 6. I'm sorry, number 7. Subject matter experts for future meetings. You see the list here. We have a lot to do still. So this committee will continue to operate. The presenters and topics listed on this slide include those we've collected from subcommittee members and/or outreach to. We will seek to have them scheduled after the October SURG meeting. Is there any feedback from the subcommittee?
Madam Chair, Ms. Lee has her hand raised.
Thank you, Chair. Recognize Ms. Lee.
Thank you, Madam Chair. so I suggested Chad Sambora from Missouri, but I would like to redact that actually, because we have somebody better right here. And that person is Donald Griffin and Black Wall Street, who have been like they are just tearing it up in Reno Sparks. And I could not be prouder of Black Wall Street, including they have placed, I believe in 9 locations, but it's probably more now. They've placed these overdose aid kits or OAK kits in lots of places where people who use drugs are. And these kits, these OAK kits, have naloxone and fentanyl test strips. And so honestly, I think it's better than the naloxyboxy that I originally suggested. And like I said, they're right here in our state, and they are doing lots of prevention and harm reduction work. They're working with adolescents and taking them on trips and working with zero suicide initiatives. And I mean, just so much, and ensuring that our underserved populations in Washoe County are really being served. And so I would love to hear from Black Wall Street instead of Chad from Missouri. Thank you.
Okay. I believe that we can reach out, and if you could give that information to Kelly, so that we can reach out to Black Wall Street. And what was the name again?
Donald Griffin is the co-founder and a good friend of mine. And I could not be prouder of the work that they're doing here in our community.
Thank you, Ms. Lee. Any other suggestions, Dr. Dixon?
Well, I can't think of anything specific. I'm just thinking what all is going on down here in Clark County, and at the moment I can't think.
Well, you have plenty of time also, that if you do have any suggestions, please contact Kelly, and our team will do an outreach to whoever you suggest. I was just going through all of us right now, since we're here, just to make sure your voices are heard. If you have any suggestions, because it just seems like you guys are really shy today. I don't know if it's Friday, I don't know if that's the case. Yeah. What about you, Mrs. Shell, Steve? You have anything?
Thank you, Madam Chair. This is Steve Shell. Nothing at the moment, but I am thinking, I know the state of Nevada is currently forming efforts to revamp the system of care for children and families. And I think some of that's going to be pertinent for our group to hear. So I think eventually in the near future, I would like to see somebody from the state come to our group and give us an update on that.
Perfect. And Ms. Cheatham?
Yeah, so I just actually wanted to clarify so I can get some ideas about future presenters. We're going to be able to make harm reduction recommendations separately from the 6 that we just did, correct?
Correct.
Okay, and is that just kind of open to as many recommendations as we want? Is there also a limit? Does it go under the 7? How will that work?
For right now, the way I understand it, and Kelly can clarify it for us, that each of the subcommittees will only bring 5 to 7 recommendations, and then we'll proceed from there to build upon. So, but Kelly, if you could please clarify.
Yes, Madam Chair, Kelly Marshall for the record. So I would just note that when we initially discussed establishing subcommittees, it was suggested that there be a separate harm reduction subcommittee. And it has become clear in the work of the subcommittees that harm reduction weaves through prevention, treatment and recovery, and response. And so my understanding is that there may be some harm reduction recommendations brought forward by other subcommittees that all of our members of this subcommittee will have an opportunity to vote on during the next SURG meeting on October 3rd. There's also a consideration that we may end up establishing a separate 4th subcommittee on harm reduction to avoid confusion about harm reduction. That has not obviously been decided because that decision would be made by all of you at either the October 3rd SURG meeting or at a later meeting where that issue is actually agendized. But I do believe, Madam Chair, that there may be some harm reduction recommendations, and it may be that the SURG, when they see our recommendations, pull out the BIPOC recommendation related to fentanyl and your recommendation, I think number 4 or number 5, and they may place that in a harm reduction category separately. It would still be included in the annual report. But obviously, until that meeting happens, we won't know how it will all shake out.
Perfect. Okay, does that help? Okay, Ms. Cheatham, go ahead.
Yes, that does help. So it just seems, since we are able to make one more recommendation, I think that it would be great to hear from someone that's working in harm reduction here in Nevada. So I liked Lisa's suggestion for Black Wall Street, or perhaps someone from Track B Exchange or Impact Exchange as well would be another recommendation.
Okay, thank you. And Kelly, I saw her taking notes. She has that one down also. All right. So I think that we can go over to agenda number 8, which is public comment. And public comment shall be limited to 3 minutes per person. Members of the public may comment on any matter that is not specifically included on the agenda at this time. However, no action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to subparagraph 2 of NRS 241.010. And Kelly, are there any public comments on the Zoom? Any hand raised?
Madam Chair, Kelly Marshall for the record, I do not see any hands raised at this time.
And
And we do
phone?
not have any members of the public attending by telephone alone.
Okay, all right. And before we go to agenda item number 9, I want to tell you, the subcommittee, that this was really a good session. I am, floored that that we've had some really good presentation and some great feedback. And I think our October 3rd SURG committee meeting will show that the hard work that we've been doing here and the hard work that our, Kelly and the staff have been doing. You guys are phenomenal, and I just want to make sure that I thank everyone publicly, because this is something that we don't normally do, and I think that we should always thank those that are in the trenches with us, helping out. So thank you all. And agenda number 9, we're adjourned. Have a great weekend.
Thank you.
Thank you.